Hello, Dr. Barb. How are you?
I'm good. How are you?
Perfect. Thank you for joining us today. Today we will chat about metabolic health for women, and I think you're probably the best person to take us through that uh, little view of how you see the metabolic health for women. So let's get started. So first of all, tell us a couple of words about yourself, right? So for those who don't know you, who is Dr.
Yeah. So I'm Dr. Barb. I am a licensed naturopathic doctor. I reside in Ontario, Canada, and of course, practice in Ontario, Canada. And I have a primarily metabolic health, women's health focused practice. I talk a lot about magnesium and how that interplays within those two roles. And we can talk about that as well later, but those are basically my two big areas of practice. And so I think women's health and metabolic health for women isn't often talked about. A lot of research, a lot of online talk is about metabolic health, mostly in men. And so men and women are different. And so it's a really interesting topic and something that I really like to address.
Perfect. So how do you explain the metabolic health to your clients or the importance of the metabolic health to your clients?
Yeah, so we have to kind of understand what metabolic health is. And a lot of people don't really understand the concept of it. When somebody says metabolic health, they're thinking automatically of weight or of, they might have a high blood pressure or something like that. But there's no real distinction on, what it actually means in terms. And so how I explain it to patients is that it's basically how well your body produces and uses energy. So when I'm thinking of metabolic health, I'm looking at how efficiently are your cells functioning, how balanced is your blood sugar and insulin, how is your body processing fats, proteins, carbohydrates, or macronutrients, and then finally, how resilient are your systems to stress and inflammation, because these are two big components that can actually alter metabolic health. And so, from a clinical standpoint, we will define metabolic health using measurable markers. And so, the measurable markers I like to use are obviously fasting blood glucose, insulin levels, hemoglobin A1C. I will do waist circumference, blood pressure, and then kind of like a cholesterol panel. And this is how we kind of look at the measurable outcomes of what we're doing. So we start with a baseline and then we follow up every 3 to 6 months and we see how things are changing from a measurable standpoint, as well as how the patient's feeling as well.
Okay, perfect. So there's a lot to unpack there, actually. Let's see if we have time. But first of all, so what are the, let's say, main one, two, three reasons that women come to you? So is it weight loss or what is the main reason?
Yeah, so most of the times women coming to me have been sent to me either from a medical doctor, their family doctor, for one or two reasons. Fasting glucose is out of range, so they're either insulin resistant or maybe even in the type 2 diabetes range, or they're coming to me because they can't lose weight. So they're at this weight loss plateau, and all the things that they used to do when they were 20 and 30 now is not working, and they can't seem to budge from where they are at.
Okay. So can you unpack the last bit for us? Because I think probably many women have faced this issue where they're reaching their 50s and they're unable to lose weight, or what was working doesn't work anymore. Maybe they see a bit high elevated glucose. So what is the role of nutrition? So what is, I mean, generically speaking, obviously, without giving advice to the specific person, but what is the role of nutrition and where do you stand in that space? So do you go low carb with some patients, or what's your opinion there?
Yeah, so to answer the first part of your question, when women come to me, they are coming to me in their mid 40s, maybe early 50s, and they're in the perimenopause or menopause stage of life. And we have to remember that at that stage of life, hormones are changing. So we have estrogen going down, we become more insulin resistant just from that heading downwards as we get closer to menopause. So the things that we were doing obviously are not going to work the same way now because we kind of have our hormones doing different things. And so we need to have a change in mentality when we're addressing weight loss. And so, lowering your calories, skipping meals. These are not the things we want to be doing at this stage because this is only adding more stress to the system. More stress is going to obviously halt anything that the body is going to want to do. So we do look at the role of nutrition. Diet is probably one of the biggest things that you can do to it's the strongest, most powerful thing that you have in your control. And it is something that you can do every single day, and that can have a great impact. So, yes, I talk a lot about diet and lifestyle with my patients. We pretty much look at macronutrients. We will start, most women are under eating like right across the board. So 1,400 calories or less is already a problem. And most women are sitting between 1,000 and 1,200 calories. And so this is not going to work very well when it comes to your hormones also changing in this period of time. And so the under eating is a real problem. We also have most women are not eating a lot of protein. They're eating a lot of carbohydrates. They're eating a lot maybe of fats, healthy fats, even indeed, but their protein content is way low. And so we try to figure out what a relatively good protein ratio is for that individual based upon their goal weight as well as their activity level. So if they're kind of active all the time and they're not getting protein, this is a stress response for the body. So we make sure that we're going to get in enough protein because protein is essential for blood sugar regulation. It helps with hormone production like thyroid and sex hormones, and it helps with tissue repair, obviously. And so we need to bring some of these foundational things back into play. And I think the other nutrition component that we're often seeing very low is fiber. So we see most women are not having enough fiber in their day. They're not using fiber to their advantage. And it supports digestion, gut health, detoxification. It prevents cortisol spikes. It prevents blood sugar spikes. And yet we're not actually consuming fiber. And so usually I will get my women to do somewhere between 25 and 30 grams of fiber per day. So we really start with the foundations of nutrition as a first step when we're looking at weight loss plateaus.
Okay, great. Thanks for that. So I'm also a big advocate of eating more. So and I do see as well with my clients that they're mostly under eating, and there is a well established mentality of we need to eat less, move more, and they end up eating, as you said, less than 400 calories, and then if they get stuck, then they eat even less, and I think it's a vicious cycle. So how do you approach calorie increasing calories, and where um, yeah, do you just increase the content so you slowly try to help the person eat more? Because I guess also satiety is an issue. So if you're in that space and you eat every day for a year or 2 years or more, 1,200 calories, then it's difficult to go up to 2,000 calories. And where is that mark where you usually, what's your goal for well, the average patient, let's say 2000 calories roundabout.
Yeah, so we definitely don't go. I mean, we still have to keep in mind that if we want to lose weight, we need a caloric decrease, right? That is still the math equation that we need to keep in mind. But I think too, what is involved in those calories is they're not eating a ton of calories and they're maybe skipping meals. But when we actually come in and put in the proteins and the healthy fats, not overdoing it, and then putting in some complex carbohydrates, they are getting more calories and they're feeling more satiated, but we're not actually bumping up like by 900 calories at a time. We might do like if they're at a 1200 calorie per day, I might go and see if we can get to around 1500 calories. And we kind of sit there. And then I also don't start them off on intermittent fasting right away because for them, it's really hard when you haven't had the caloric intake that you need and you don't have the macronutrients you need and your blood sugar's all over the place, intermittent fasting can be really difficult for those individuals right away. And so I usually start with the foundations. Like I said, I get their protein up, I get their fiber up, I put in some complex carbs, and we add some healthy fats, and we kind of take it one meal at a time. And I think the big thing I really stress on the first visit, 3 meals per day. Not six, not five, not two, 3 meals per day. We want to get a nice foundation. We want the body to become like accustomed to a certain rhythm. And so many women that I see, they're eating like 5, 6 times a day and they're having a snack here and then they're having like a semi meal and they might have another snack. And then it's really the consumption of food, even though it's less calories, is actually more detrimental to their blood sugar, to inflammation, and all of those things, which is causing a lot of that weight plateauing that they're experiencing.
Great. Because that's exactly the way we start also in Keto Box. So we first week of the program, we say 3 meals in a day. We don't mention about intermittent fasting, eat to satiety, increasing or moderating, in this case, protein. So protein, how much do you aim for? So we know the RDA is 0.8.
Yeah.
Probably go a bit higher, but where do you put the goalpost?
So it depends on how much activity the individual is doing. So if the individual is doing, exercising 4 times a week and it's pretty, heavy lifting, kind of resistance training, maybe a HIIT workout somewhere in there or something like that, then I'm going to look at a higher, probably like a 1.5 to 1.7 grams of protein per kilogram of weight. Um, but most women, if they're coming to lose weight, I've kind of set them between the 1.2 and 1.5 grams, even if they're not, moving as much as maybe somebody who is working out 4 or 5 times a week, just because we need to get that protein in to help with hunger hormone regulation and blood sugar regulation. They are coming in on a very carb heavy diet. They know what it feels like to get that spike of energy, but then also come crashing down. And then they eat again, and then they go up and they come down and they eat again. And it's this cycle that just continues all day long. But my protein goals for them usually are around the 1.2 to 1.5 if we're kind of trying to get them out of a plateau. And if they start to increase activity levels, I usually don't go higher than 1.7, 1.8. I tend to find that it's too much, and women aren't really, unless they're like into some really bodybuilding kind of activities, they're not doing incredibly well when they've got that much protein to try to eat in a day. So I generally deal 95% with women. It might be different with men, but for women and women in their late perimenopause, early menopause, this is kind of the target area.
Yeah, I'm also aiming there. So I even maybe try to aim for the lower side, so 1.2, for example. Um, because also but in this case, also the nuance is that in the context of a nutritionally complete diet, you still don't want to create immense satiety by eating too much protein, which means you don't get the rest of the macronutrients, right? So you eat only salad and chicken, for example. I think that's still not the probably the ideal type of setup. I'm not sure if you see that with your clients as well, that they eat mostly protein but nothing else. So because this is the typical, at least in Greece, diet, you want to lose kilos, okay, you will do some protein, a bit of salad twice a day maybe, and that's 800 calories max, and that's
Yeah. So this is what we talk about in the first visit is like the healthy plate. So I go right into it with them. Like I want to see half a plate of vegetables. So that can include some salad, but I'd want some form of vegetable on there. I want a protein that's in there. Also, I really strive to get them to put in some form of fat, just because you're right. Like a lot of people will just have protein, or they'll just have protein and some salad and these calories, and they in their mind this makes sense to them because they're like, okay, there's no carbohydrates there, and I'm not eating a lot of calories, and I'm going to lose weight. But that backfires. With metabolism and especially in women on with thyroid health, right? So we have to really teach patients to, what a healthy plate looks like. And I like to include a complex carb, especially at dinner time for them. And it will add to the caloric intake. I try to keep breakfast and lunch more protein, healthy fat, fiber rich. And then I put the complex carb at dinner for them. And it just seems to like once they're educated on kind of what their plate looks like, they're not so regimented to just having a piece of lettuce and some protein. And so I think it's really about educating what a plate should really look like in with their whatever it is that they're trying to achieve. But yes, we want to get away from because they will tend to do that because they think that this is not a carb and this is going to make them lose weight. So I do a lot of education around the under eating component, the cortisol response that happens, the stress response that happens, and how the body just doesn't work that way. And we need to kind of give it what it needs, especially if they are active individuals. And from there, we move forward. But it's really all about educating them in that first visit so that the mentality is greater than just the lettuce and the protein
Yeah.
on the plate. Yeah.
I think education is the biggest part
Yes.
of the journey. Uh,
Yes.
and so you mentioned a couple of things. So insulin and complex carbs. So you mentioned that you propose to some at least that they eat their complex carbs in the evening. So I guess complex carbs, you mean rice, potatoes, or something of that sort, or beans. And maybe you can clarify that. And the second is, do you have any scenarios where, or what's your stance between insulin? I mean, in the morning we're more insulin sensitive. In the evening, maybe we don't want such a high insulin spike because it's coming, it's evening, and we want to relax, and maybe it blocks melatonin, for example. What do you think about that?
Yeah, so complex carbs, I'm looking at legumes, I'm looking at sweet potato, something like that, as far as complex carbs. Maybe not going as far as, pasta or anything like that. That's more like a refined carb to me. Quinoa, sometimes I will like allow or budge on because it does contain some other things. But that's primarily complex carbs. And then the reason I put them at dinner, especially for women, I find is we have a longer time to dispose of that before they eat their next meal. So my suggestion to patients is always leave 4 to 5 hours between meals so that we can come back to baseline. We know that this whole process takes about and this is the glucose, insulin, like once we eat and the sugar is broken down and moved into the blood and then into the cells and insulin's released and all of that. That's a 4 to 5 hour process. And so if we can get things to come kind of back to baseline before we eat our next meal, we're not kind of compounding on top of each other. And so the reason I like to put it at dinner is because at dinner, most people are not eating until the next morning, which is now 12 hours. We have a lot more time to dispose of that insulin or glucose. But I also get them to do the food ordered eating. So I get them to, if they're having the complex carb, I'll get them to eat the vegetables first and then the protein and then the carbohydrate. Just because we know and research shows that the insulin response is much lower when we are getting in the fiber initially and then the protein and then having the carb at the end. It's kind of coming in for the ride. So I get them to do that as well, just to kind of help with that insulin response. But I don't know, here in Ontario, we have a 2 hour oral glucose insulin challenge test. And so I will send patients to the lab for 2 hours. They will get a drink that kind of is around 70 to 75 grams of carbohydrates. And then they take the blood work every half hour kind of thing, or every hour. So they'll come in fasted, they'll do the blood work for glucose and insulin. And then 30 minutes later, after the drink, they get their first blood draw for glucose and insulin, and then at the 1 hour mark, and then at the 2 hour mark. So I get a lot of patients to do that test because that's going to tell me where they're at. Like, what is their body doing when exposed to carbohydrates, glucose, those kinds of things. And then I can pretty much give them a pretty detailed, individualized plan based upon what their body is doing. So, is their pancreas actually releasing insulin? Because some people don't. Is their body producing too much insulin for what they're consuming? And are we actually getting back to baseline at or similar baseline to at the 2 hour mark? We should be, back to kind of where we started with glucose after the 2 hour mark. Now, if they're still at 7 or 8, then we have a problem. We know that their body isn't able to handle that glucose or insulin challenge. And so that just gives us a lot more information how to structure their plans. And so if someone is producing a ton of insulin, then I am looking at, the insulin demand index. So, what foods are lower on the insulin demand index. So although cottage cheese and Greek yogurt are like all the rage and they have all the protein, they're also very insulin stimulating. So those foods will be gone for somebody who produces a ton of insulin because that food, although it has protein, it is an insulin stimulating food. And so for the time being, until we get things regulated, we do remove it. So it really allows us to get honed in on what's actually happening with that individual.
Yeah, I think it is one of the most informative tests that one can do. And very few people do it because, first of all, they only measure glucose. They don't typically measure insulin, even by itself, but that's even a snapshot. And this actually gives you a pretty well or accurate picture of what is happening in real time. So everyone should do it. I think that's a great advice. And you can indeed target your suggestions very, very well. The other thing I'm just as a note is what I'm also doing recently is also measuring the metabolic rate of the person with one of these little devices that measures RQ. And I find also RQ a quite interesting number because it gives you in that resting phase if you're actually burning fat or glucose or carbs or glycogen, maybe more accurately. And we see that a lot of people after 12 hours are still stuck into burning mostly carbs, whereas even in a non-keto type of diet, after 12 hours of after your last meal and after sleep, you should be relying on fat. That's why you haven't eaten. and you tap into your body fat, and then the body should be a lot more happier.
Yeah, I don't use that currently. I find that most of when patients are coming to me, their problem really is in that blood sugar insulin kind of realm, and we really try to deal with that because I find that food, regardless, is like it's a big thing for everybody, right? It's
Mm.
something we're exposed to every single day. And I try to stay with things that people can do um in on a regular basis, and that is something part of their everyday day. But I think it's fantastic that you could use that measure and then also get people thinking more about, okay, maybe we need to do some work because my body's not actually able to burn fats. And that's really another thing what metabolic health is all about is that metabolic flexibility, right? That flexibility to be able to burn glucose versus fats and stuff like that. And so I think it's really important. And you're right. A lot of doctors don't run fasting insulin. Here in Ontario, unless we specifically ask them to run it, and most of them will not run it. Um, they only run glucose or hemoglobin A1C, which is a 90-day glucose
Yeah.
average, right? So in my practice, like we are allowed to requisition blood work. So I will always order a fasting insulin or a 2-hour glucose insulin challenge test. And those are probably my biggest tests because they give me the best information, and then I can work from there to put together a plan for that patient as to how their body is responding. And the other thing I like to use a lot too, especially at the beginning when someone is coming in and their inflammatory markers are up and I know their insulin is just crazy high, is I'll usually do like a 5-day fasting mimicking diet with them to kind of get things started and get things kind of reset. And sometimes I will even do this for 3 months in a row, once like one 5-day measure or one 5-day diet plan kind of thing per month for 3 months to kind of really get them off of that roller coaster of just inflammation and insulin and all of that.
Is this the similar to the Dr. Longo model where you do 500 calories per day for a few days?
Yeah, so I get either the patient can order the Prolon, which is the Walter Longo's 5-day fasting mimicking diet. It's available in Canada, so they can order it online and they get the package and everything is there and they do it. But I've also come up with my own through just regular foods, keeping with the standards of what he did in the research. So for patients that kind of want to have everything done for them, they will order the package. And for patients that kind of maybe want to do their own cooking, or it's not a lot of cooking because you're not eating a lot of things during the 5 days, but there is some prep involved. And so they will do the one that I've.
Very interesting.
Mhm.
Um, Thanks for all the advice. I think people will find it really helpful. Uh,
Yeah.
you mentioned a couple of times stress. Maybe you want to unpack this for us a bit, because I think also when we're talking about insulin resistance, uh, I mean, most people will discuss diet, but when we're talking about, okay, what is the root cause of insulin resistance? Many people will, in that context, start talking about stress, and maybe it's more important than what actually we think or most people think.
Yes. And stress it's a big topic because we can look at mental stress, physical stress, cellular stress, right? Like this isn't just one component. It's not just, I think when people hear stress, they think of, oh, something's going on in my life and I'm stressed. And I often ask patients, what is your stress like? And they're like, oh, it's fine. And because that's all that they're associating it with. And unfortunately, the stress response goes much deeper and much further than that. And so cortisol obviously is going to be our main stress hormone. And during, longer periods of stress, it's going to not regulate your blood sugar as well, right? So its job is to modulate and mobilize glucose into the bloodstream, and then it that whole process happens. But if we don't have cortisol where we want it, or cortisol levels are really high, then we start ending up with dysregulated blood sugar and we start seeing more inflammation coming in. And inflammation is also another result of that stressor. And this happens in the body sometimes as well with oxidative stress. So if something, the free radicals that we hear about often in different research studies, these are like kind of it's almost think of it like a rust on the cell, right? And so that is causing stress. And so these are all touch points that we have to address if we want to actually deal with insulin from a complete perspective, because it's not always just the physical stress that we experience in life that is driving that insulin. Even sleeping, like if we don't have adequate sleep and we have a night where we're not sleeping well, or we have many nights that we're not sleeping well, cortisol starts to elevate because that's a stress response within the body. And then we start to see more blood sugar dysregulation. We start to see more inflammation. So it's very much encompassed in how people function from all aspects of lifestyle. It's not just the food you eat or the physical stress that you actually experience from a day to day. And I think that in today's world, we all have it. We all have stress in some capacity, whether it's mental, physical, emotional, cellular, it doesn't matter. We all are going through it. And so we have to keep that in context when we're looking at insulin.
Yeah, yeah. I read somewhere recently that we are the only species that we can put ourselves and keep ourselves into a stress state. So
Yeah.
it's our fight and flight, right? So which is normal, but then we can be 24/7 in that state, and that's probably where a lot of the problems come from. So where do you actually, or how do you measure stress? Because also, I think a lot of people talk obviously about cortisol, but not cortisol alone, but cortisol in relation to DHEA. And maybe you're using other markers. What should one be looking at when we're talking about stress, apart from obviously insulin, glucose, etc.?
Yeah. I do. I do look at AM cortisol. I look at PM cortisol. Sometimes I will do a 4-point cortisol kind of test to see kind of what they're doing during the day. Um, I would say that I do look at DHEA. I mean, that is adrenal, and we know that that's where cortisol kind of comes from. Many people have very low DHEA, so we do a lot of adrenal work around that. But those would be probably the two biggest ones because they're giving us the most information about what's actually happening with the hormone. And then from there, we put into place something to either elevate DHEA or something to reduce or modulate cortisol. Like a lot of people have either very high cortisol in the morning, like higher than what is normal, or they're in the tank. They have nothing. And so we know that both of those are problems. And so that's giving us kind of an idea of what's going on first thing in the morning. And we know that blood sugar regulation starts kind of during the night and into the morning. And if they're having, this huge spike in cortisol in the morning, more than what we actually require, then we know that that is an issue we need to address before we actually start doing a lot of the other things. And so I would say that those two are probably the biggest. Sometimes I will also use inflammation markers because inflammation markers can sometimes give us the amount of stress that is actually on the liver. For instance, if we're looking at CRP, or if we're using like ESR, which is more of a systemic inflammation, kind of what is the position of the body as far as cellular health. And so I will sometimes use inflammatory markers for that. But we have to be mindful of this cortisol stress because if we're constantly stressed, your body's just constantly pumping out glucose. Like it doesn't matter what you eat. And this is what I explain to patients. You can have the perfect diet, but if you have all this cortisol and all this stress going on, you're really not like your perfect diet isn't actually helping because what's happening is the body is just constantly pumping out that glucose, even if you don't need it. And so this is something we have to address.
Yeah, and I think this is something that also I'm really interested in. I'm really looking into it because the other number no one is measuring is glucagon, right? And then a lot of people, especially in the keto space, are starting to talk about what we call insulin suppression, where maybe insulin is very low, but then you have extremely high glucagon, which actually drives potentially a higher glucose. And I mean, maybe for in keto is a bit different, but at the end, yeah, we want to stress is, I mean, in how the body perceives it, it's very simple. It's either we are in a fight or flight or rest and digest, right? And we want to be able to regulate that. How do you usually regulate that? I mean, high level. So what are the main guidelines? Because I would guess nutrition is part of it, but not only, right?
High levels of insulin, do you mean?
No, how do you regulate high levels of stress,
Oh,
cortisol?
stress.
Yeah.
Yeah, so we definitely implement, well, it depends too what type of stress is. Like if they have physical stress, obviously we're going to try to get them into more of a rest and digest kind of parasympathetic state. So whether that is, incorporating some meditation, getting outside nature, walking, exercise, anything like that, that can kind of help with that nervous system. If it's more mental emotional, we try to get them to, A, seek out what is causing that, and B, we also try to support the nervous system. So I'll use like several different types of magnesium. I'll use L-theanine. I'll use adaptogens if I'm finding that, cortisol is really high or they're not having a good adaptogenic response. I'm also doing a lot of, some people will like, especially in the space of weight loss. And because we have been fed this, you need to be exercising, exercising, exercising all the time. I get a lot of women coming in and they're doing all this exercise and they're actually over exercising. So they're over stressing the body. And so we need to start to pull back on some of that. And honestly, that is the most difficult conversation that I have with patients because in their mind, exercise is almost like a drug for them. And it's great because we know the benefits of exercise, but the consistent and the back-to-back hard resistance, strength training, cardio workouts are actually backfiring and it's not allowing for that rest and recovery, which is causing stress on the body. And so that is another thing we have to look at and pull back on so that that body doesn't feel like it's always in this fight or flight state. So it really depends on kind of what the individual is dealing with and where we need to kind of intervene. But a lot of it is nervous system regulation through supplementation, through lifestyle factors, or also supporting adrenal health, which is really, really important.
Yeah, the exercise part you mentioned is really big and something I'm actually also working with myself because sometimes you get into that mode and maybe it's you feel it's stress relieving because it is stress relieving for the brain, for the mind, but doesn't help you overall. So yeah, thanks
Yeah.
for okay. So the we talked about nutrition, we talked about stress. Maybe a third component, which actually ties the bow very nicely, is also digestion, right? So if we're too stressed, maybe the digestion is failing, or if we think we're eating a good nutritional diet, but again, we can digest it properly. Um, so we are what we digest, maybe, or what's your thought about that?
Absolutely. Digestion is a big piece, and it's a piece that a lot of us don't have a good a good overall handle on. So obviously, when women are coming in and they're in this weight loss plateau or they have weight issues, a lot of them have digestive issues. They have the bloating, the gas, they have constipation. Some of them have IBS. So there's always, I find, a digestive component that comes with that. And we have to remember that digestion is probably at the root of most things, whether we're talking about hormones or metabolism, it plays a role. And so it's something that we definitely have to address, and it becomes part of that nutrition component with my patients. It's always included in their treatment plans. And, sometimes too, like it depends. Like if this person is highly has a lot of bloating, has a lot of gas, has a lot of stomach pain, those kinds of things. Sometimes we'll do stool testing. Stool testing is very expensive in Ontario. Not everybody can afford it. If I feel that, they can't do the stool testing, then sometimes I will just do a 4 to 6 week antimicrobial kill of their bacteria to kind of level things out, to kind of stabilize. And that sometimes is another factor that can move the needle in the right direction. If we get a stool test, we know exactly what bacteria are kind of out of range, and then we can be a little bit more specific. But those are kinds of things that we start on. We also, you know, will provide all the digestive tips and things that most of us know but don't do, like eating in a rest and digest phase. We're not eating on the run in front of a computer screen, doing our work, all the other things, right? So I usually get people to, just sit down, take 5 deep breaths before the meal, and just kind of get into that parasympathetic state so that digestion can actually occur. Another big one is chewing your food. Most people are not chewing their food, so we're now starting to swallow whole bits of food that your body has to try to start to break down. And because it's, and I mean, a lot of people don't have enough stomach acid, so then they can't even break down their food the way that it's supposed to be broken down. And then it sits there and it ferments and putrefies, and, hence we've got bloating gas coming. But so I'm getting people to chew their food 20 to 30 times before swallowing so that it's like at a baby food consistency. We're going to support stomach acid. A lot of people with reflux, bloating, that their deficiencies are sometimes stomach acid. So including bitters, apple cider vinegar, digestive enzymes sometimes if we need them. One of the other big things that I've picked out from patients is many of us like to drink when we're eating, like water, alcohol, doesn't matter, any fluids. So really, I get them to stop fluids 15 minutes before, 15 minutes after, just because that's going to dilute our stomach acid, and it's going to obviously not give the proper ratio. And so if you actually need some water, just sipping maybe 1 or 2 sips if needed. Otherwise, just keeping fluids away from foods. And then just including fermented foods. So fermented foods have a lot of great probiotic bacteria that we're not getting in probiotics that we're swallowing. And bitter foods, right? So arugula, dandelion, ginger, sauerkraut, kimchi, all of these are really great. And the nice thing about these are you don't need a ton of them. Like for the fermented foods, often 1 to 2 tablespoons per day is all that you need in order to get what we need from that food. And so it just helps to support gut microbiome and, a lot of the digestive secretions that we need to be having.
Cool. And is it more about removing or adding? Because we talked about what we can add, probiotics, and I wanted your opinion. So I usually like kimchi and kefir. So these are my two goes, I guess, uh, and sauerkraut, I guess. Is this your list as well? And the second question is it again, what things do we need to remove, or what things do you think potentially people having difficulty digesting? Because maybe someone is talking about legumes uh, because they have lectins. Other might talk about bread,
Yeah.
obviously, etc. So what are the danger foods there.
Yeah, and that's going to be very individual. I am not one for a blanket statement of everybody needs to go gluten free. This is something that is very much talked about online and everywhere in the space. There are definitely certain areas, certain situations where yes, gluten can be a problem, or dairy for that matter. But it depends. So if I'm looking at dealing with leaky gut and we're trying to do a leaky gut protocol and, if they have IBS and we're trying to do some gut lining support, I will sometimes remove gluten and dairy for 6, 8, 12 weeks in order to allow the gut to kind of heal and to support the gut. But I also do a lot of celiac testing. So if they're coming up, like I've diagnosed a lot of celiac in my practice that, were not diagnosed before. So that is something we have to keep in mind. But we do have non-celiac gluten sensitivity out there in some individuals. And, when we remove the gluten, it makes a world of difference. And like I said, with dairy, I mean, yes, we're going to remove, but we might only remove certain portions of dairy. So, like I said, if we have a lot of insulin release in an individual, we're going to take out those insulin stimulating dairy foods. And that is when we're going to remove them. Do we remove them forever? We don't likely have to, but we will remove them for a time. And then we can see how your body responds kind of when we bring it back in. Certain conditions that are highly inflammatory or where I see patient has a ton of inflammation, then I might look at, removing maybe gluten as an inflammatory component for a while to see if numbers come down, see how they feel. Oftentimes when we do some of these trials, some people don't go back on gluten even though they can, because they do feel better. And so it really is individual. And a blanket statement of no gluten is just, I don't think it's warranted because some people do well on it and they don't have an issue with it. And I think we just have to be more mindful where we're putting that blanket statement. But I do usually just do a case by case basis and I make a decision based upon what I see in the picture.
Is there any particular food or thing that where you put a blanket statement? Are there things that you say, okay, here I draw the line and that's for everyone?
Yeah, this might be a little bit controversial because I know there's a lot of controversy going on about this, but I put a blanket statement on seed oils. I know there's a whole group team out there that says they're not inflammatory and they don't, impact us the way that, some other research has shown that they do. Um, I am just of the mindset I don't think we need to have them in our diets. If we can have cleaner oils and cleaner ways of cooking our foods, then that is my choice. And so that would probably be my one big blanket statement. My second one is probably processed foods. And this is just in general because we know in processed foods, we are getting some of these seed oils, we are getting lots of different additives and coloring and all kinds of stuff that is contributing to inflammation, to insulin, to all of these things that we're talking about today. But those would probably be my biggest two blanket statements that I would say to patients. But yeah, yeah,
Think I agree there with you as well. And even though I'm a keto guy, I don't consider carbs to be a problem. I think the maybe handling carbs is a problem, but not per se carbs. So, and I think probably processed foods, or not probably, I'm as well of the opinion that processed foods and seed oils are there at the top, probably causing most of the issues.
yeah, yeah. And I mean, processed foods, they just contain the ingredients that, the sugars, the salts, the sodiums. Like, I mean, it's sometimes what I'll get patients to do is I'll be like, okay, I want you to go home and for the next 2 days, I want you to record all the sodium you intake from everything you eat. And what they come back with is like we're in the 4,000, 5,000 range of sodium, but this is because a lot of the packaged foods contain so much sodium. And so they don't realize that. And then they wonder, oh, why am I retaining water? And why am I bloated? And I don't feel good. And a lot of that has to do with just some of the things that they're getting from these processed foods, right? So yeah.
Yeah, can very easily add up. Indeed. Uh,
Yeah.
we covered a lot of topics, but maybe not the one, at least on social media, that you're actually the most famous for, if I may say so, which is magnesium. And I know you've written a couple of small books about magnesium, and I have to recommend them to people because I also bought them and I think they're really well written. Tell us a bit about magnesium.
Yeah, so magnesium is one of my favorite minerals. I do a lot of education around this mineral on my social media sites. And it's a mineral that doesn't get a lot of attention, doesn't get a lot of spotlight. But it is a mineral that does so many things. And as of the latest research, it is responsible for 800 enzymatic reactions in our body, which means, in very simple English, it's got its hand in almost everything that happens in our body. Um, we are mostly deficient. I'd say 60 to 70% of the population is deficient in this mineral. Not because, we're not taking magnesium or we're not eating foods that are magnesium, is because magnesium becomes depleted very easily by some of the things that we've talked about today. So if we're highly stressed, if we have insulin resistance, if we're inflamed, if we, sweat when we work out, we are losing magnesium in all of those scenarios. Medications, 1 out of every 3 individuals are on some form of medication that actually depletes magnesium. And if we're not replenishing it, or at least bringing it into the capacity that we're losing it, we are going to become deficient. And so although we lose it from like insulin resistance and stress, it also helps with insulin and stress. So this is why we need to make sure that we have adequate amounts of magnesium, whether we get it through food, whether we get it through supplementation, or whether we get it transdermally. But it is a topic that is very near and dear to my heart. Yes.
Thanks for that. And is it so? I hear that, or what you're saying is that everyone more or less should watch out for their magnesium intake, and the RDA is 400 milligrams. So would people benefit from, I mean, if they put their numbers in chronometer and they think that they're getting what at least they think from their food and they're around that 300, 400 milligram range, um, would they probably still benefit from adding some supplementation of magnesium?
Yeah, so this is what I wrote in my second book, because what and how I do this in practice is I kind of look at the individual and I look at everything in their picture that is depleting magnesium. So if they're insulin resistant, they have alcohol, they drink lots of coffee in the day, they are on a medication that might deplete magnesium. I look at everything that could possibly be depleting their stores of magnesium. And then I look at what I actually want to have happen for them to improve their health. So whether I'm trying to deal with insulin or glucose, or whether I'm trying to reduce inflammation, then I look at that, and then I look at kind of what their diet looks like. And so in some people who are depleting, and I kind of look at, okay, so they're depleting all of this, and then they're eating this kind of a diet. Sometimes the 400 milligrams that's only the recommended dietary allowance. So that is the minimum we need to not be in a deficiency state. That isn't always mean that it's optimal. And so some individuals need double that. They need like 600 to 800 milligrams, because they have so many things that are depleting their magnesium that we need to actually bring in a little bit more to substantiate what they're losing, plus what we want it to do for their individual bodies. And so Food obviously doesn't have as much as it used to as far as nutrients and minerals and those things, but I never discount the food. I think it's foundational. I think that's why in my second book, the second half of the book, it's all about magnesium-rich recipes and how much magnesium we can actually get from food. And I actually list the amounts of magnesium so that you know what you're eating. Um, but I think that adding food in is just like such a benefit because magnesium is rich in a lot of plant foods and in some fatty foods, so like avocado and salmon and those kinds of things. And it can make a big difference in somebody's life if we can actually get them eating 400 milligrams of magnesium and then we supplement the rest. But we're also getting much more benefit from the food that they're eating that's high in magnesium for many other reasons as well. So, short answer, it's not enough usually for the average individual unless we're like no stress, no inflammation, no nothing. So,
Perfect scenario. Yeah.
yeah.
And would people feel the difference? So is it like we supplement, I don't know, another 400 grams or so? Would we see, like physically or mentally, see a difference in 1 or 2 weeks or so?
Yeah, and that's going to be dependent again on the individual and how far or how much is going on in their health history. So I have had patients who have noticed the difference within days, so like 2, 3 days, and then I've had patients that have noticed the difference within 2, 3 weeks. So usually within a month, you are going to notice some form of difference. Um, and I think too, we have to make sure that we're taking the right form of magnesium, the right dose, and at the right time. And a lot of people will come into my office and be like, "Well, I tried magnesium and it doesn't work." And I'm like, "Okay, so where were you doing this? What were you taking and how much?" Because the form, the dose, and the timing is really important, depending upon what you're trying to do and what that patient is dealing with. And so if you're taking a medication that's depleting magnesium and you're taking your magnesium right after it, we have a little bit of a problem there because the drug is always going to win when it comes to pathways. And so we just have to be a little bit more strategic when it comes to dosing the form and the timing of magnesium. And we talk about that in my first book with Dr. James D. Nicolantonio and how we can make magnesium a little bit more absorbable in some people's cases. So adding vitamin B6 can be helpful in the absorption of magnesium into the cell. So yeah, like it's really it's a mineral that we don't have, there's a lot of studies on it, but we don't talk about it enough. And I'm really trying to change that. And I'm trying to bring forth as much education as I can surrounding this mineral. And yeah, and I mean, like, it's the other big thing I think that a lot of people don't realize is that we need magnesium in order to activate our vitamin D. And when we look at the deficiency of vitamin D and the deficiency of magnesium, that is not a coincidence. That is because if you don't have enough magnesium, you actually cannot activate vitamin D in your liver or your kidneys because that enzyme that is required is maintained by magnesium. And so a lot of people will say, but I'm taking D3 and it's active and that's all great, but it still needs to become activated in the body so the body can use it. And so this is another big thing when we're looking at people who have immune system issues, inflammation, insulin, and those kinds of things.
Yeah, James is talking about it a lot, actually, that we need to combine D3 with magnesium at the same time. And maybe that's one little trick and hack that people can keep. And I guess there is a lot of more hacks, or not hacks, but information that we need to discuss when it comes to dosing and timing, etc. But probably that's in part two of our discussion, if I may say, because we don't have enough time. And I think that requires a podcast by itself.
Yes, yes, it's a big topic. Yeah, yeah.
So, thank you very much. It was a pleasure talking to you. I'm pretty sure not only the women audience, but also men learned a lot about metabolic health and insulin and nutrition. And I would like to thank you again very much. Maybe you want to close by telling us where the people who are interested to get in touch with you, where they can find you.
Yeah. So you can find me most likely on Instagram. I have my account on there. It's at Dr.Barb. I speak, you'll see it's all about magnesium. And I also have my links there for the books if you're interested. They're all available on Amazon, and you can look at those. They're written very easily to understand because it's a lot of technical terminology when you're taking research and trying to put it into everyday language. So it's written so that it's easy to understand, and it has a lot of information on all the different health conditions and how magnesium is required for those health conditions. So either book is great. And my website, which is just barbwoger.com.
Perfect. Thank you very much, Dr. Barb, and I hope we keep in touch. It was great
Thank you
chatting.
so much for having me. And yes, I'm happy to do a part two if you'd like in the future.
Perfect. It's a deal.